This is Anthony Effinger. I'm the host of the Think Neuro podcast here at the Pacific Neuroscience Institute. And today I am interviewing Dr. Adi Iyer. He's a neurosurgeon with a specialty in vascular diseases of the brain and spinal cord. Thanks for joining us.
Thanks for having me.
So tell me, what are some of the diseases, vascular diseases of the brain and spinal cord?
Yeah, the most common disease of the brain is probably stroke, in which a blood clot occludes one of the major arteries of the brain, preventing blood flow from going to important territories. Other problems are things like brain aneurysms, which are little ticking time bombs or balloons that can burst and cause devastating bleeding within the brain. There are arteriovenous malformations, which are little tangles of blood vessels in which arteries are connected directly to veins. And a high-pressure system connected to a low-pressure system, they can rupture and burst or cause all sorts of debilitating things like seizures. Then there are other less common things like fistulas, which are little connections of arteries, sometimes outside of the brain, to veins. And then there are diseases of the caliber and the size of blood vessels, so carotid artery disease, stenosis of the carotid artery, something called Moyamoya disease, in which all the blood vessels clamp down or are narrow, and even young patients can have strokes. So it's a wide variety of things that I can treat.
So this is all sort of the blood plumbing of the brain, is that?
That's exactly right.
Okay.
It's plumbing of the brain.
So every way to get blood flow to the brain.
Exactly.
Okay. When you say an aneurysm is a ticking time bomb, what is that? What is that exactly? We hear the word aneurysm all the time, but what is it exactly?
Yeah,
because it's just scary sounding.
Great question.
Sure.
It's very scary. Yeah. So aneurysms, for the first thing is they're very common. About 1 in 50 Americans will have a brain aneurysm. It's about 1 in 20 to 1 in 30 worldwide. And
seriously?
Yeah. And what it is, it's just a weakening in the blood vessels, usually at one of the branch points. And when a blood vessel gets weak, over time, that weak area can start to grow and grow, almost like a balloon that starts to blow up over time. And one day, with just bad luck, bad genetics, high blood pressure, that balloon can just pop open. And when it does, that can be really devastating.
Oh boy! Now that's when you need emergency surgery, correct?
Correct. So if an aneurysm ruptures, patients will know right away. So it'll often present as the worst headache of your life. And it'll be like a light switch goes off. Even if someone's had headaches or they have migraines, this will be different. This will be just like a lightning bolt hits them. And, the rule of aneurysms are when they rupture, it's the rule of thirds. So 1/3 of patients won't even make it to the hospital. The next third of patients who do make it to the hospital will leave with severe disability. And a third of patients that do survive, may have some independence, but they'll have some moderate disability as well. It's very rare for patients to have a ruptured brain aneurysm to come out completely unscathed.
So you're talking about a disease that's going to hit 1 in 50 people in the United States?
The good news is the majority of patients with aneurysms will never know about them. They'll never rupture.
Oh, okay.
There's certain predisposing factors, which we can talk about, but the majority of aneurysms don't rupture and actually don't even need to be treated.
So you can have an aneurysm that's fine.
Mm-hmm.
It's a ruptured aneurysm that's the problem.
That's the problem.
Okay.
Yeah.
Okay.
And all that we do is to prevent the aneurysm from rupturing, or when it does rupture, to prevent permanent disability.
So can you detect an aneurysm before it's ruptured?
Excellent question. The majority of aneurysms that we detect before they rupture are incidental, meaning patients are getting imaging or MRI scans, CTs for other reasons, and you just happen to find an aneurysm there. Oftentimes, patients will be screened if they have a strong family history, if everyone in their family has had an aneurysm, for example. Or sometimes, in the rare case, patients will have neurological deficits. They'll have a little bit of double vision, a pupil won't look right, and they'll get screened. But many times aneurysms are never noticed.
It's something that you have and you die with it. Correct. Of something else.
Exactly.
Okay, I feel a little better now.
Yeah.
So what do you do when you're treating, say, an aneurysm that you find that hasn't ruptured? What do you do?
Good question. So if you find an aneurysm that hasn't ruptured, luckily we have a lot of data to see what the risk of rupture is for that particular patient. And every patient that I see in my office, I'll put all their information into a calculator. So I'll put their age, their risk factors. For example, are they smokers? Do they have hypertension? Certain genetic predispositions? What's the size of the aneurysm? Where's the aneurysm located? And have they ever had a bleed before? I'll put that all into my calculator and I can tell the patient with pretty good accuracy what their risk of rupture is. And if the risk of rupture is not that high, or the patient's, elderly and their life expectancy isn't too high and the risk of rupture is low, we can just leave it alone sometimes and watch it. But if it's a young patient with a higher risk of rupture with a long life ahead of them, it may be, worth the upfront risk of treating it in order to prevent them a lifelong, morbidity or mortality.
Sure.
Yeah.
So two things. One, when you talk about the size of an aneurysm, what are we talking? I mean,
good question.
Pea, softball, pin.
They can range from peas, a couple millimeters, to giant aneurysms, which can be 2 to 3 centimeters. So
a bulge in a vessel?
I treated an aneurysm last week, which is about 3.5 centimeters, about the size of a golf ball.
Where was that?
It was a middle cerebral artery aneurysm in a gentleman who was in his 50s who didn't know about it until it had ruptured.
Oh my gosh! Where in his body was this thing?
Yeah, this one was actually easier to access. It was right here, kind of in the temporal region, and just as soon as you took the bone off, you just saw this big golf ball sized aneurysm.
Oh my gosh!
There. But they can be very large.
So what did you do in that case?
In that case, this patient had a hemorrhage, so he required emergent surgery to take the pressure off the brain, evacuate all the blood clot, and then fix the aneurysm. So in this case, when it was so large, you actually had to cut the aneurysm open and reconstruct the blood vessel with a series of titanium clips.
So you're taking out the bulge, say, in a pipe that's broken, and you stitch it back together.
Yes. Usually the aneurysm, you don't stitch it back together. Sometimes you have to do a bypass in which the aneurysm is so large that there's no way to really fix it. So you just cut off circulation to it and then bypass circulation past it. So the rest of the blood vessels past the aneurysm get blood flow, but the aneurysm no longer receives blood flow. In this case, we were able to clip reconstruct the aneurysm, meaning put some titanium clips across the neck of the aneurysm to prevent it from filling and still maintain the patency of all the normal blood vessels.
So the thing is just sort of isolated off the vessel.
Correct.
Interesting. Yeah. Now, what was his outcome? What's his...
Good question. So despite having a devastating bleed, he's able to move, he's able to follow commands. When aneurysms rupture and patients survive, it can take months to even years of significant rehabilitation to recover function. And kind of the mantra is once the air hits the brain, you're never the same. So once they have surgery, once there's bleeding in the brain, it can alter patients, but my goal as a doctor is to help them and their families get through it and kind of see them through recovery, whatever that may mean.
Now, he showed up because that had ruptured. Is that right? Okay. So tell us about when you get somebody where you have an aneurysm that has not ruptured. What's the procedure?
Yeah. So again, if it hasn't ruptured, I'll put all those numbers into a calculator.
Right. Yeah.
If it's a high-risk aneurysm, we'll talk about treatment options.
Okay. And then what? Every
aneurysm is different. So some aneurysms are better approached with open surgery. Some aneurysms are better treated with endovascular procedures with little catheters.
Okay, so stop there. So you're trained in both of those. That's two different things. Open is opening up your body, your head in this case, correct?
Correct.
And tell me about endovascular.
Yeah, so the analogy I like to think about the way to treat aneurysms is like plumbing, for example. If you ever had a pipe burst in your house, sometimes there are two ways to fix the pipe. Oftentimes you have to excavate the concrete, dig it out, find where the leak is, fix the joint from the outside of the pipe. And that's what I think of as open surgery. Every now and then you can go in with a roto-rooter and a camera and a snake and go from inside of the pipe, see where the leak is, and patch it up with some sealant or something like that. And that's the endovascular approach. So with the endovascular approach, you'll make a small poke either in one of the arteries of the wrist, which is what I do these days, or traditionally in the groin and the leg.
That's what I've heard about. Right.
And then you use X-ray imaging, usually in 2 different planes, so 3-dimensional X-rays, to guide a series of catheters, which are plastic, thin plastic tubes, and wires, really, really thin, platinum wires, all the way up inside the arteries of the brain through the neck. And from inside the arteries of the brain, you navigate your way, almost like solving a puzzle, to get into the aneurysm. And from inside the aneurysm, you can seal off the aneurysm from the inside with some platinum coils, which are like little silly strings, which conform to the 3-dimensional shape of the aneurysm. Sometimes you can do a stent as well, which is you use these metal braided tubes to put across the aneurysm to prevent flow from going into the aneurysm.
So it stays there.
It stays there.
It stays there. Does it still have blood in it?
The goal is to prevent the aneurysm from filling with blood.
Okay, got it. Now, why platinum?
Good question. To platinum, it's non-ferromagnetic. It doesn't set off a metal detector. It's biologically inert, and it's very, very soft and conformable. If you feel these things, it's finer than hair.
So, and what is the structure again? What are we using platinum for here? For
these coils.
Coils that do what again?
So you want to seal off blood flow from inside of the aneurysm.
Okay.
So what you do is you get a little catheter, which is a little plastic tube, and you put it inside the aneurysm itself.
In there, in the bulge.
It's in that bulge.
Okay.
And then from inside that plastic tube come out these little 3D silly string platinum coils, and they'll conform to the right shape and size of the aneurysm and prevent that aneurysm from filling up with blood.
No kidding. So you're sort of putting a structure inside this aneurysm that could be anywhere from the size of a pea to
a couple millimeters to a few centimeters, yeah.
How do you drive? You mentioned X-ray imaging, but how do you drive that catheter? How do you know where to turn?
Yeah, good question. You create maps of the body and the blood vessels by injecting dyes in different arteries, and you look at that map on a screen, and your hands are controlling and rotating wires with different shapes on it at the wrist, and you're looking at the screen and kind of navigating those wires through that map that you've created.
Wow.
So it's
Are you good at video games?
I was very good at video games.
Were you really?
Yeah, much to my parents' dismay when I was a kid, but turned out to be a more valuable skill than they had thought.
Is it helpful, really?
Yeah.
Which ones did you play?
I grew up, it was the 80s, so the Sega Genesis, the original NES, and Super Nintendo. So all the Mario games, Donkey Kong, Sonic.
And so that dexterity with a controller is actually...
It's the same thing that I do every day.
Are you serious?
Yeah, I get to play video games every day. It's the best job in the world.
What percentage of your surgeries are open versus endoscopic, would you say?
Endovascular. Good question.
Excuse me, endovascular.
It's I really try to keep it about 50-50.
Really?
The nice thing about being able to do both is I can really think about what's best for that patient. They say when you're a hammer, everything's a nail. So if you can only do one of the two things, you only see that patient with the lens of what you can offer. But it turns out to be about 50-50 in terms of what's best for the patients.
Interesting. And so you're ready with any either procedure. I mean, depending on
on that individual patient, what their aneurysm looks like, how old they are, their comorbidities.
Now, when we were talking a little before this, you mentioned that during surgery, sometimes you have to control something with your mouth. Is that correct?
Yeah. So, surgery. It's. I think of being a surgeon almost like being a musician. You have to use your ears to hear what's going on in the room, hear the vital signs. You have to use your all your senses. Obviously your eyes. And for me, I like to always have both hands in the field to be 100% focused. And we operate with a microscope, so I control the microscope with my mouth. There's a little mouthpiece that attaches onto it, and you move it around freely with your mouth. So it's kind of one coordinated, orchestrated movement.
Wow. So both your hands are doing something, either guiding the stents or sealing off the aneurysm, say, for that example. Mm-hmm. And then your mouth is
moving the microscope. Usually my left foot is adjusting the focus and zoom of the microscope, and my right foot is on a coagulation pedal. So it's
what is a coagulation pedal?
It's just a cautery device. If you need to cauterize between two poles of an instrument called a bipolar. So all four extremities are being used.
So the cauterization, that's burning something to close it or to...
Yeah, exactly.
And that's deep inside again. Where
Yeah.
So this is a full body...
It's a full body...
I did not know that.
Yeah. No, I think physical stamina is just as important as mental stamina in treating brain aneurysms. I think it's, wellness and health and having your body and mind sharp are paramount.
How do you train? How do you prepare?
Good question. I have a morning routine. I wake up at 5 o'clock every morning. I exercise religiously.
Doing what?
I do it all. I lift weights. I do a lot of cardio, but it's a daily thing.
Every day.
I chase my kids every night. That's a good cardio.
Okay, so you're physically prepared.
Yeah.
Okay,
yeah,
what
you
about
have to
mentally?
be. Mentally too, you need it's about adrenaline control, I think. You have to always be calm, always be in charge, never lose your focus. It's kind of meditative in a sense, but no, I think having a good mental state and positive outlook is the most important thing. You always have to be positive. You always have to feel confident.
Now, did I read that you played drums for a while? Speaking of the multi-limbed
Yeah.
endeavor that this is.
Yeah, I used to play drums and guitar. Yeah.
No kidding.
And I still play a little piano, actually. I'm trying to get back into it.
Okay.
Yeah.
And so I can see how these are kind of related. Like, is that, again, like the video games, is it helpful to be a drummer who having to use independent motion with all these limbs, or is that a reach?
Yeah, no, I think that's actually a perfect analogy. Yeah, I mean, in fact, even in drumming, when you do all your rudiments, you learn about independence. I mean, if you play double bass drum, which I play, each foot has to be independent, each hand has to be independent. So, yeah, it's
Fascinating.
similar.
And so did you play in college?
I played in college.
Okay.
Yeah.
And then what? So let's talk a little bit about your origin and how you came to medicine.
Yeah.
To say you're highly trained is kind of that's not saying enough. I looked at your resume, but so tell me where you started.
I started a few miles away from where I work today, actually, in the Valley in LA. I grew up in Northridge, which is in the Valley.
Yeah.
Went to the LA public school system. I went to high school in North Hollywood. Interestingly, where my wife went also, but didn't know her back then. Then I went away to New York for college.
To Cornell?
Mm-hmm.
Okay. And what did you study?
I studied math.
Math.
Theoretical math. Suffered for 4 years there. Just it was purely theoretical math with very little applicability. Then I did a master's degree in applied math just because I kind of liked it. It was challenging, but I think it wasn't quite for me in terms of the tangible output I got from it. So I made the switch to go to medical school. So went to Pennsylvania for medical school, and then I came back to California, to Stanford for neurosurgery residency.
How long is that?
The residency is 7 years, and
7
and then the
years.
fellowship is 2 years.
So 9 years.
Essentially, yeah, it's a long road to.
That's got to be one of the longest, right?
Yeah, neurosurgery is the longest.
Yeah.
Yeah.
And when did you know you wanted to be a neurosurgeon?
Yeah, when I went to medical school, you experiment with all the different specialties. And pretty early on, I realized I wanted to use my hands and I wanted to be, more engaged physically in what I do. I tend to get, distracted or bored with things easily. And I think neurosurgery is the one field in which there's always something interesting. There's always something challenging. It kept me really engaged. And pretty early on, probably the second or third year of medical school, I met some mentors. And I think once you have the right mentors and people you want to emulate and look up to, it kind of sets your path for what to do.
And now a message from our sponsor. The Think Neuro podcast is brought to you by Pacific Neuroscience Institute Foundation, a nonprofit 501c3 organization. If you're inspired by what you hear and wish to support our mission of education through innovation, please visit pacificneuro.org/foundation. So who was one that comes to mind? Are they anybody? I don't imagine they're household names, but they're probably eminent in the field.
Yeah, one of my first mentors was a pioneer in radiosurgery. Dade Lunsford was his name.
Radiosurgery is...
It's a field of neurosurgery that actually uses radiation to treat things like brain tumors and AVMs and so forth. But he was a really esteemed neurosurgeon, a gentleman.
Is that gamma knife?
Yeah, the gamma knife, exactly.
Okay,
yeah.
Where you're using radiation to
kind of zap parts of the brain. Yeah,
by having these things converge
exactly
inside the brain.
Exactly.
Okay, right.
Yeah, I actually don't do much of that today, but
what's the status of that? Is it still sort of? I remember, wasn't that sort of going to be?
Yeah, and I think it still is.
Okay.
I think it still is a game changer for a lot of difficult to access and treat tumors and malformations, AVMs, trigeminal neuralgia even.
That's let's just tell everybody what that is.
Trigeminal neuralgia is a facial pain syndrome in which most commonly one of the arteries of the brain by the brainstem is pushing on one of the nerves that allows you to feel in the face, and that irritation can cause a sharp, excruciating pain that can be really debilitating to patients.
That's not the disease? Is that the disease they call the suicide disease?
It is. It is.
Because the pain is so intense.
Yeah.
You treat that as well?
I do, yeah.
Okay.
I do.
And you have a colleague here who treats a lot of that.
I do. Yeah, Dr. Barkadarian does a lot of that too.
We've talked to him about that.
Yeah.
Sounds, but it's not in that case. The patient often gets relief just like that,
Yeah,
don't they?
yeah, it's really gratifying.
I can't imagine. Yeah,
It's really gratifying. It's a relatively straightforward operation. That's not very invasive.
maybe
and-
for you.
Well,
But yes,
it's
in
really,
terms of
it's really gratifying
neurosurgery,
to do.
yeah.
Yeah, it's a very gratifying
Yeah.
thing to do.
Okay, so after that 9 years, where did you go?
So yeah, at Stanford, one of my early mentors was a guy named Gary Steinberg, who was the chair of our department. And I was immediately drawn to him, the cases that he did, his personality. He's just a really high energy, kind of go-getter, always driven. And I wanted to do exactly what he did. And he treated brain aneurysms. So, I followed him around for those 7 years, spent a lot of time with him, probably irritated him a lot, but, went to all of his cases. And, that's how I trained to do brain aneurysms. And these days, if you want to treat aneurysms, you also have to do the endovascular, the route as well. So there's a guy in our department named Michael Marks, who was a radiologist, who again was a great mentor of mine and taught me how to do the endovascular techniques.
Wow. Do you remember the first surgery where it was you were in the driver's seat completely on your own?
Oh, absolutely.
When you were, when was that? What was that like?
Yeah, it was, it was my second or third year of residency. It's probably my second year of residency. It's probably a basic case in the middle of the night, the hemicraniectomy. But
what's that mean?
A bleed in the brain
Okay.
that it needs to be evacuated right away just to take the pressure off. And I remember there's no one around. And, pretty early on, I realized that, when you're the surgeon, you just have to take charge. You have to own it. And, early on, almost fake it till you make it. Fake the confidence, and one day you'll become confident.
Hemicraniectomy, does that mean taking off
Taking off the bone, yeah.
half of the
Which
of the brain,
Yeah,
bone in your skull?
Yeah.
That must have been a big deal.
As a second year resident at the beginning of, 14 months into being a doctor, to be able to do that was, obviously it was a big adrenaline rush, nerve-wracking, but also once it was completed was, gratifying to know that, you're learning to develop skills to save a patient's life.
Oh my gosh, yes. So what was it like going from the very theoretical world of the math major that you started to the very hands-on world of surgery?
Gosh, that's an excellent question. I think it took years of studying math and being inside my own head to realize that I wanted to spend my time with people and make connections and impact lives in a more tangible way. So for me, it was really gratifying to go away from being in an isolated desk with a sheet of paper and my own thoughts to being able to do something like this and meet people face to face.
Because you're a people person, clearly.
I think so.
Yeah.
I think so.
How did that training help you, though? Did it?
Yeah, math is it's intense problem solving. It's using logic and deduction. People think math is just calculations, but I completely disagree. I think math is actually it's using logic. It's forming arguments and making rational decisions, and it's essentially what you do in medicine. Every time you solve a problem in medicine, you kind of go from step 1 to 2 to 3 and kind of find the more kind of the most logical way to get from one place to another. So for example, if I'm treating someone with a brain aneurysm, I have to think about all the factors of their age, their life expectancy, what their risk factors are, what their anatomy is, and come up with a decision tree of what the best treatment is for that patient. And it's similar to it's similar in terms of the deductive skills, I think.
Sure. Sure, that makes sense. When you described a calculator for figuring out treatment. Describe that a little bit. Is it like a something on the web that you put numbers in? And
It is. Yeah. So, for brain aneurysms, because, it's such a prevalent disease, we have a lot of large data sets in which we can, calculate based on just some statistical inference what certain risk factors are for that patient. So there are different scores and calculators. I like to use one called the PHASES score. It's PHASES. And it has to do with the patient's population. Are they hypertensive? What's their age?
Population meaning they're...
Are they, are they North American
Okay.
versus, say, Japanese, Finnish? Certain populations have higher risks of aneurysms.
Which ones are those?
The two known ones are Japanese and Finnish.
Why? I wonder why that is.
Yeah, they must have some genetic predisposition.
Interesting.
Yeah.
And what are we talking about? A much greater?
A slightly higher risk.
Slightly higher,
Females, for example, have a 3-to-2 ratio of aneurysms compared to men.
What does that mean?
So for
every 3.
for every 2 men that have an aneurysm, there are actually 3 women that have an aneurysm.
Interesting.
So
Okay,
women
so
have
it
a higher
breaks
risk. Yeah.
along.
So gender.
Yeah.
Hypertension is a big factor.
High blood pressure. That seems obvious.
Age, over 70, under 70.
Smoking.
Smoking, and prior rupture as well is a big one. If you had a prior hemorrhage from an aneurysm, it would make more sense that the current aneurysm you have is going to rupture.
Has anybody studied sort of the people must have studied the sites of these aneurysms to determine what's going on there biochemically or physiologically or something?
Absolutely. Yeah.
What do we know?
Yeah, so the aneurysms are categorized into anterior circulation and posterior circulation aneurysms. And that's essentially based on where the primary blood supply to the aneurysm is coming from. Is it coming from the carotid arteries in the front of the brain or from the vertebral arteries in the back of the brain? And generally, the posterior circulation aneurysms have a slightly higher risk of rupture than the anterior circulation aneurysms, with some exceptions. And that probably has to do with the flow dynamics of those aneurysms and where they're located. Aneurysms by the brainstem, deep in the back of the brain, when they rupture, can be a little bit more devastating because some of the structures around there are so much more critical.
Certainly, you're talking about like
The
what?
brainstem
Yeah.
and some of the cranial nerves.
The stuff you really can't do without. Okay. Is there anything about the anatomy of the back, the arteries in the back, or is it the same kind of level of blood flow? Is it one bigger than the other?
Good question. Everyone's kind of wired a little bit differently.
Okay.
We're all built with something called the circle of Willis, which is, a set of connections that connects the arteries from the front of the brain, from the anterior circulation or the carotid artery circulation, to the back of the brain or the vertebral artery, posterior circulation. And
What did you call that?
It's called the circle of Willis, and it's essentially there are little connections that connect all the arteries from the front and the back of the brain. And everyone's circle of Willis tends to be a little bit different. Some people have a complete circle of Willis in which every artery is connected to the other artery, and those patients tend to do pretty well because they have enough what we say collateral circulation.
There's other routes
There are other routes, exactly.
for the blood flow.
It's almost like if there's traffic, and
You can go take the side streets.
exactly right.
Okay.
You can take the side streets. For example, I got stuck here on the 405. I was able to go around in Sepulveda and take Sepulveda all the way up. And
Same thing here.
the same thing in the brain.
But other people, don't
Other
have
people,
those
those connections aren't complete. So they may have some arteries in the front of the brain that aren't connected to the back of the brain. Those patients have slightly higher risk of of not being able to tolerate strokes, ischemia. They may have higher risk of forming brain aneurysms because there's more pressure. That's not evenly distributed.
I wondered about that.
Yeah.
Is that's a thing? Not having evenly distributed pressure in the brain, and these connections, greater connections, take the pressure
They
off.
dissipate that pressure a little bit.
It's so
Correct.
interesting.
Yeah.
What would be considered normal in your circle of Willis?
Yeah, a normal circle of Willis would be to have what we call an anterior communicating artery, which connects the two arteries in the front of the brain, to have two posterior communicating arteries that are all sizable and enough to dissipate, blood flow. But again, everyone's wired differently, and a perfectly normal circle of Willis or a complete circle of Willis is the exception rather than the norm.
I was wondering in what percent of people do you think ballpark?
Gosh, I'd have to look
would
this
be.
up.
Are we talking like? Is it? 50,
I'd say the
is it
majority
10,
of people
is it-
are incomplete. It's about
Okay.
50% are incomplete.
50% are
I'd say about
incomplete.
25% are complete, and 25% are very incomplete.
And are those people potentially
Probably at slightly higher risk. Again, a lot of the stuff hasn't been studied.
Yeah, it hasn't been. What about the circle of Willis with regard to, say, Finnish and Japanese populations? Is anybody...
Good question. I don't know if the difference between those populations in terms of having a higher prevalence of aneurysms is due to a variance in the circle of Willis, or rather a difference in their, the collagen vascular profile of their blood vessels in general.
Collagen...
The actual structure of the blood vessels and the cellular structure of the blood vessels may be different.
Interesting. Yeah. When you're in there, can you sort of tell differences from what you can see in the microscope in the collagen structure of the vessels, or no? Does everything kind of look the same, or is it like, wow, this is really different?
Yeah, every aneurysm will look different on the surface.
Yeah.
Some aneurysms can be very calcified and rock hard from atherosclerotic disease from high cholesterol. Some aneurysms are extremely fragile and friable, meaning that they can just break on a whim. They can break very easily.
So when you're in there,
they're just fragile like tissue paper.
And that's a problem.
That's a problem.
Well,
they can both be problems, actually.
Which? The tissue paper and the...
They both have their own range of difficulties. When an aneurysm is really calcified and rock hard, oftentimes when they're doing surgical clipping, the closing force of that spring-loaded titanium clip may not be enough. So you have to come up with more creative solutions. Multiple clips, bypass options. We now have reinforcing clips. So you put a clip that engages another clip to increase the closing force.
And this is all, again, this can be open or it can be...
Endovascular,
Endovascular,
So
right?
So again, with the fragile aneurysms, the really fragile ones, those are more likely to have intraoperative perforations, so the aneurysm can burst
when you're in there.
Yeah.
Okay.
Either a little catheter or wire can cause those to rupture.
And then what?
Then you have to fix it right then and there.
Right then and there. Well, at least you're in there.
Yeah. So if it's open surgically, you can see where the bleeding is. You can control it. If it's endovascular, once its aneurysm's started to bleed, you have to control it either by quickly putting coils in there or having a balloon temporarily occlude the artery.
Does that mean running other things? Forgive me if this is the improper way to say this. Does that mean running other equipment up through the catheter?
Yeah, so when I do an endovascular case for a ruptured aneurysm, I'll always have a balloon prepared.
Right.
It's just in my practice, yeah. So if, God forbid, there is an intra-procedural rupture, which can happen about 7% of the time in the literature, I have a balloon there ready to go.
On the table.
And
somehow
get it up there, blow the balloon up, and stop the bleeding. Usually if you have the balloon open for a couple of minutes, the bleeding will stop.
Okay. And how fast can you get that balloon up there?
Good question. Within seconds.
Really?
Seconds to minutes.
Does it just run up the line like the Roto-Rooter?
Yeah, usually, I use a triaxial system, so I'll have, a catheter in the wrist, a catheter up in the carotid artery. We're called an intermediate catheter, which is a catheter that gets you very close to the aneurysm, through which you can guide little microcatheters. So once you have that catheter that's close to the aneurysm, you can just guide a microcatheter up there or a microballoon right up there very quickly.
You're there.
And you're there.
That's fascinating.
Without having to re-navigate your way up.
How long is a typical aneurysm surgery?
Good question. A straightforward middle cerebral artery surgery can take an hour.
Really?
A really complicated, basilar artery aneurysm or a giant aneurysm that requires a bypass and trapping can take, half a day.
Oh my.
The endovascular treatments tend to be a little bit quicker. And in my opinion, they tend to be a little bit more, well tolerated by patients.
Yeah.
So if I can offer an endovascular approach that's durable and safe, that tends to be my first line treatment.
Again, because what you're saying, air when you get.
I think once the air hits the brain, you're never the same.
Yeah.
I do think we can do open surgery now in a much more minimally invasive way. Now we do, eyebrow craniotomies for ACOM aneurysms, for example. Small incision through the eyebrow that disappears.
Just little tiny.
Or what we call a mini terional, which is just about 2 inches in front of the ear to get to most circle Willis aneurysms. So the incision can be very small. The amount of bone I take off is about the size of a $50 at most. So surgery is less invasive,
Than it was back in.
but endovascular approaches are the least invasive.
Yeah. So it makes sense for, yeah. So when did you join PNI? How long have you been here?
I've been here just a little over a year now.
Oh, that's it.
That's it.
And how is it?
It's been great.
Yeah?
Yeah.
What do you think? What do you have here? What does PNI have that you like? I hear it's very collaborative.
It is. So I'm primarily in the Valley. So I'm the only PNI neurosurgeon that treats patients in the San Fernando Valley. So I'm Burbank and Mission Hills. But I think we have a pretty, esteemed department of, renowned neurosurgeons here, comparable to any major academic center.
Yeah.
But I think because we're a little bit smaller, we're able to offer, more personalized care and spend some more time with patients, and we're not, driven by some of the motives of major institutions. It's more about the physicians and the patients. And also, we're able to engage in research. We're able to, collaborate across multiple disciplines. We have neurologists, headache specialists, ENT, ophthalmology, neurosurgeons, neurologists. We're all here.
So you can tap any of those specialties if you need to.
Yeah.
Yeah. How many days a week are you operating versus clinic?
Good question. I take a lot of call, so I'm on call about 25 days a month. I do 1 full day clinic, 1 day a week.
Clinic means you're just
seeing patients in the office.
They're coming in, you're checking them out, you're saying
surgery, no
what's
surgery.
next? Okay.
See you back in a couple of weeks. Yeah.
That's 1 day a week, and then you're doing call how much?
About 25 days a month. Yeah.
That is almost the whole month.
It's almost the whole month, and between the two, services I provide, the endovascular and the open, every day I'm doing something. So I've got cases.
Now, is that a choice?
Yeah, it is. Yeah,
it is. You love it?
I love it. Yeah.
You do?
I love it.
So being on call means you get called.
Yeah, all night, all day, all night. I mean, I don't know how long it'll be sustainable, but.
So you're doing that 25 days a week, and you also have small kids.
Yeah.
Yeah. So you're good without sleep.
Good without sleep. Yeah.
So what do you think the future is for your specialty? How do you see it evolving? How do you see technology helping people deal with these problems?
Yeah, good question. I think personalized medicine is probably the most important change we're going to see. That there'll be better screening tools. Solving the human genome, we'll be able to identify exactly what patients are at risk for, who should be screened, who should be treated, who has a higher risk of, for example, aneurysm rupture versus not. I think the personalization of medicine is really going to be key.
Do we have the markers for those things? Do we know them in the genetic code yet?
Not yet.
Okay.
There's a small subset of patients for whom we do, but the majority of patients we don't. So I think that'll be a big game changer. I think brain tumors need to be... we've made such little progress on malignant brain tumors in the last 40 years.
Yeah.
So that's something that I think, will be the next, frontier for neurosurgeons.
Yeah. Do you do any work on glioblastoma?
I do. Again, my focus is vascular problems of the brain.
Right.
But
does it bump into that ever? Or?
A little bit.
Yeah. So if you weren't doing this, what do you think you'd be doing? Playing drums in a rock band?
Probably, yeah. Probably playing music or doing something, yeah.
Do you still play at all?
I've been trying to play a lot more piano lately.
Yeah.
I haven't played in years, but one of the first purchases I made when I moved back to LA was a piano, and I try to play a little bit every day.
Nice. Fantastic.
Yeah.
Well, thanks for joining us.
Thanks for having me.
Yeah, it's been great, Dr. Iyer. Thank you.
My pleasure. Thank you for having me.
Great.